Mr. Dayananda Babu sir and our surgery, Dr. Sendil sir to be with us to next session on the hernia. Initially, we will have 10 to 15 minutes on a general perspective and the how to approach the hernia case. Then we will have a case discussion.
Shaktivel, sir. Shaktivel.
Shaktivel. What is hernia? I will be talking for a few minutes, followed by person. What is hernia?
Hernia is defined as an abnormal protrusion of whole or a part of viscus through a normal or an abnormal opening to the wall that contains it.
Very good. So that is the definition of hernia. Whenever we think of hernia, we think of inguinal hernia. But you have got other hernias. The groin hernias are inguinal, which may be direct or indirect. And we have got femoral hernia. Those are all groin hernias. The groin region is the weakest region in the body. Something called the Achilles heel. When the man has attained erect posture, this area, because the area between the transversalis, the transversus abdominis muscle and the inguinal ligament, which is covered only by the transversalis fascia. So that is the weakest area there. There is something called shutter mechanism. When the abdominal muscles contract, the transversus abdominis will contract and that will come and hit against the inguinal ligament. But when the muscles are weak, this part is the weakest, especially in the standing position. That is why it is called the Achilles heel of the abdominal wall. So also, you have got something called the myopectineal orifice. The myopectineal orifice area is both in front of the inguinal ligament and behind the inguinal ligament, through which the femoral hernia is good. So the direct inguinal hernia, indirect inguinal hernia, femoral hernia, all the three hernias are coming out through the you know the boundaries of myopectineal orifice? Tell me. Very good.
Myopectineal orifice is bounded medially by the lateral border of rectus abdominis
Very
and
good.
superiorly by the arched fibers of internal oblique muscle and laterally by the iliopsoas muscle and below by the pecten pubis.
Pecten pubis, that is the pectineal line. So that area is the area through which these three hernias are coming. That is the myopectineal orifice. That is why in the keyhole surgery, they put a mesh to cover all these openings. That is the myopectineal orifice of fracture. Myopectineal orifice of fracture. Then you have got other hernias. So usually you have got classify hernias into the congenital hernias, the acquired hernias, then any other?
Ventral hernias.
Ventral hernias are totally different. What are the ventral hernias?
Umbilical hernia.
Umbilical hernia.
Epigastric hernia.
Epigastric hernia.
And spigelian hernias.
Spigelian hernia, very good. And also, nowadays, they include the incisional hernia also. Previously, we used to think of incisional hernia only in ventral hernia. Nowadays, all these things, that is the epigastric, the umbilical, the paraumbilical terminology as such has gone. Now they talk about only umbilical hernia. The paraumbilical and umbilical together, umbilical hernia, and then the incisional hernia, everything together. So again, the incisional hernia is acquired after surgery. So together they are called ventral hernia. Any other hernia you know? Then the lumbar hernias are there, the superior lumbar, inferior lumbar, so many hernias are. Then the inside abdomen you have got internal hernia. So not only that, these are all external hernia we are talking. Internal hernias are there. Example?
Parastomal hernias.
Parastomal is different.
Diaphragmatic hernias.
Diaphragmatic is, again it is. You have got paraduodenal hernias. The intestines will protrude through the peritoneal fold and produce hernia. So you have got internal hernias and external hernia. We are talking about commonly is the external hernia. Whenever there is hernia, the intestine or maybe omentum or sometimes appendix, those structures will go inside the sac. So the hernia will have a sac. The sac will have coverings. This is the structure. The sac has got three parts. What are the parts of the sac?
Fundus, body, and a neck, sir.
Fundus,
Body,
and
neck.
The parts of sac. The sac will be covered by maybe the various layers of the abdominal, and then you have got content. So three things are there: sac is there, content is there, coverings are there. So they may ask for any hernia, they may ask, always you should think of the content when you make a diagnosis. And then of course coverings are also important, and the knowing the neck of the sac, whether the hernia, why the inguinal hernias are important and why you are operating is because of the fact, what is the main reason you operate?
So it can go for obstruction and strangulation.
The complications. The 5 complications. I have always tell 5 What are the 5 complications?
Irreducibility, obstruction, strangulation, and inflamed hernia. The contents
and incarceration. So these are the 5 complications. So always you should know the complications. So because of the complications, we advise surgery which may be open or the keyhole surgery. That is, we will be talking about it little while later during your presentation. So this is the basic concept, that is knowing the anatomy, knowing the inguinal canal. What is the anatomy of the inguinal canal?
Inguinal canal is an oblique intramuscular passage between deep inguinal ring and the superficial inguinal ring. It is bounded anteriorly by the external oblique aponeurosis, and in its lateral 1/3 by the internal oblique aponeurosis, and the superior wall is formed by the arched fibers of internal oblique and the transverse abdominis, and the floor is formed by the grooved upper surface of inguinal ligament, and the posterior wall is formed by fascia transversalis and partly in the medial half by the conjoint tendon.
Very good, very good. So these are the boundaries of the inguinal canal, and the difference between inguinal canal in children and adult is what?
In adults, the inguinal canal will be oblique, sir, whereas in children it will be like a form of straight line, sir.
It is the deep ring and the superficial ring are almost overlapped, so that because the muscles are weak, you don't have to do a repair in children. Herniatomy alone is enough, but in adults we will do some sort of repair. So think of the anatomy of the inguinal canal, anatomy of the femoral canal, then the myopectineal orifice which we have mentioned, the myopectineal orifice of Frachat, then of course the various other types of hernias, and then the parts of hernia, the content, the sac, the coverings. So this much is the basic for any hernia. You want to talk?
You talked about the contents of the inguinal canal anatomy. What are the contents there?
In males, it consists of a spermatic cord and the ilioinguinal nerve, and in the female.
Can you trace the ilioinguinal nerve from where it comes and where it goes?
Sorry, ilioinguinal nerve starts from the lumbar plexus. It arises at the lateral border of psoas major muscle and passes laterally downwards over the quadratus lumborum muscle. Then at the level of iliac crest, it pierces the transverse abdominis aponeurosis, and it lies in the intermuscular plane between the transverse abdominis and the internal oblique aponeurosis, and then it enters the deep inguinal ring and it passes.
Ilioinguinal nerve. Is it enters through the?
It does not enter the deep inguinal ring. It in turn enters through the intermuscular passage, and then it passes out through the superficial.
Again, it pierces the muscle and comes. It is not coming with the spermatic cord. So what are the parts of the spermatic cord?
Spermatic cord consists of 3 arteries, namely testicular artery, artery to vas deferens, and the cremastic
So tell
artery.
me from where do you get a testicular artery?
Testicular artery is a direct branch of abdominal aorta.
And anterior branch, posterior branch?
It is a lateral branch.
Lateral branch.
Then cremastic.
Both sides, right and left. Right and left is also from aorta.
Yes, sir.
Okay.
Then cremastic artery is a branch of inferior epigastric artery. Then artery to vas deferens a branch of superior vesical artery. Then
Which is a branch of?
internal iliac artery.
So one is from external iliac, one is from the internal iliac artery. Oh.
And it consists of pampiniform plexus of veins, then vas deferens and remnants of processes.
Trace pampiniform plexus.
Pampiniform plexus, it comes from the bottom of the scrotum and it enters the deep ring and then superficial inguinal and then enters the inguinal canal.
Where it drains?
Usually in the right, it drains into testicular vein. The right testicular vein directly drains into the inferior vena cava, and the left testicular vein drains into the renal vein, which in turn
Artery, there is a it comes both from the aorta, right and left. But when you say the testicular vein, right is different insertion, drainage, and the left is different. Okay. You said vas deferens. Can you trace the vas deferens?
Vas deferens, it is a continuation of epididymis. Caudal end of epididymis continues as vas deferens. Then it also receives a duct from seminal vesicle and continues as ejaculatory duct and opens into the verumentanum. Ejaculatory duct opens into the verumentanum.
It is not continuous with the ejaculatory duct. The spermatic, the seminal vesicle also joins with this, and they both join together and opens into the. So very good. So what are the fascias of that your inguinal canal? Layers surrounding the spermatic cord.
There are 3 layers, sir. External spermatic.
In the inguinal canal.
Inguinal canal, it is only 2 layers, sir.
So what is the importance? External spermatic fascia is not a coverage of inside the inguinal canal. External spermatic fascia only comes out. When it comes out of the superficial inguinal ring, you are going to get that. Okay. So what is these 3 layers coming from?
So the external spermatic fascia is derived from the external oblique aponeurosis, and the cremastic muscle and the fascia is derived from the fibers of internal oblique, and the internal spermatic fascia is derived from the fascia transversalis.
So what is external oblique muscle? From where it comes? The audio, please check for him. It is okay. Oh. Go ahead. You are right.
The external oblique muscle
Now it is okay.
arises from the middle of the shaft of lower 8 ribs, and it passes vertically downwards and laterally. And inserts from the xiphoid process along the linea alba into the pubic space, and the inferior margin folds upon itself and forms the.
What is superficial inguinal ring?
Superficial inguinal ring, it is an inverted V-shaped defect present in the external oblique aponeurosis just above the pubic tubercle.
What do you mean by inverted V shape?
So it's a sort of some triangular defect in the external oblique aponeurosis above the pubic tubercle. There will not be any base for this. Only the pubic tubercle forms the base of it. So it's an.
So how will you identify pubic tubercle?
From the insertion of adductor longus tendon, we can identify pubic tubercle, sir. Or else from first by palpating the pubic symphysis, and then we can trace laterally and find the pubic tubercles.
So what is deep ring?
Deep ring, it is a defect of the fascia transversalis present.
Audio, okay, there is something. Louder, because the last row is there, people are there.
Deep inguinal ring, it is a defect of the fascia transversalis present midway along the line, between the line joining ASIS to pubic tubercle, marginally lateral to the femoral artery pulsations.
So here again, this is a controversial point. Where is the deep inguinal ring? Thus will say pubic symphysis to the anterior superior iliac spine. The new Bailey, 27th and 28th Bailey are saying pubic tubercle and so what is the best way the Bailey will say?
Femoral artery pulsation.
You feel the femoral artery, it is above the femoral artery, you are going to have a deep inguinal ring, below the femoral artery. So ideally it is pubic symphysis, but unfortunately now Bailey and Love says it is a pubic tubercle. So your examination, when you are going for NEET PG, if the question is there, you can only follow the NEET Bailey and Love. So according to Bailey and Love, it is a pubic tubercle to that. Okay, then what are the other derivatives of the transversalis fascia?
The fascia transversalis also forms iliopubic tract, then internal spermatic fascia.
What is bundlet of Thompson?
Thompson iliopubic tract is
Iliopubic
also
tract.
referred to as
What are the other two layers? Again, another one controversial point, lacunar ligament or Gimbernard's ligament. So now the anatomy says it is a part of the transversalis fascia, not an extension of the inguinal ligament. So it's a transversalis fascia, forms the Gimbernard's ligament and also Cooper's ligament. So all, and what is fossa ovalis?
saphenous opening is also referred to as fossa.
Here in his deep inguinal ring, the medial side, the thickened part of that.
Interfoveolar ligament is
So that is also formed by the transversalis fascia. What is transversalis fascia?
it is a fibrous fascia like covering, it's a fibrous layer that covers the inner part of transverse abdominis muscle. It is a continuation of diaphragmatic fascia.
How many layers?
2 layers.
So what are the spaces created by the transversalis fascia? You are aware? Space of Bogras, space of Retzius,
retropubic space.
retropubic space. So what divides this space of Bogras and space of Retzius?
The iliopubic tract.
No, iliopubic tract we will not see. What is this in between these two layers? Any vessel which?
Median umbilical ligament.
What is that artery which goes there?
Inferior.
Inferior epigastric artery can divide this. The lateral to theirs is a space of Bogras. Medial to that is a space of Retzius for that. Now you can go for a case presentation.
I think, sir, straight away you can give MS. No MS student will answer like that. If I am the examiner, and if I have got the power, I will straight away give, because none of our PGs will answer like this without any extempore like that. So you are given MS by me. Your name is
Shaktivel.
Shaktivel. Powerful man. Right. You can present case.
My patient is a 64-year-old male from Ithamoli who is a petrol pump attendant by occupation. He came to the OPD with chief complaints of swelling in the left groin for past 2 years. History of presenting illness. The patient noticed the swelling in the left inguinal region 2 years back. While bathing, it was insidious in onset, progressive in nature. Initially, it was around 2 x 2 cm, and now it progressed to attain the current size of 5 x 5 cm. The swelling increases in size on cuffing. Initially, it got reduced on lying down, but now it is only manually reducible. No history of any swelling in the other side of groin or anywhere else in the body. No history of any pain over the swelling. No history of urgency, frequency, hesitancy and difficulty in micturition. No history of a poor stream of
Can you
urine.
explain that? What is urgency, what is frequency, what is hesitancy?
Urgency is increased desire to micturate, sir. The individual can't control the micturation, while the frequency will be normal for these individuals.
Frequency is?
There will be increased desire to micture. He cannot control the act.
No, frequency.
What is frequency, what is urgency?
Urgency is there will be increased desire to micturate, sir. He can't control the micturations. So it is urgency.
No, he can't control means what?
There will be increased desire to evacuate. Once the bladder fills, he feels to evacuate.
That is not urgency. Frequency, the number of times he passes urine, how many times he passes urine is very high. Urgency, he gets a desire, he wanted to go to the toilet. If the toilet is far, he cannot hold that. So on the way itself, it will go, not on sitting the place.
How do you ascertain frequency?
So the number of
Yeah, your patient. How do you ascertain frequency?
we can ask for the history of nocturia, sir.
Nocturnal. Usually we ascertain the nocturnal frequency. Why? Why not daytime?
So it is usually the earliest symptom the patient.
No, not early symptom. Daytime nobody remembers. How many times? Night the patient will remember. How many times he got up for urination. So that patient will remember. So the patient will be telling the real number. Daytime nobody remembers. That is why always in the history also you should be very specific. How many times you get up for urinating? The patient will tell. So that is one of the symptoms which is dependable for hernia. Any other symptom, urinary symptoms, So most of the time what happens is students will tell no urinary complaints. Because if you ask the patient, he may not be remembering about the night, but definitely you should ask night. Okay. Any other symptom?
Hesitancy of
Hesitancy. What is hesitancy?
inability to initiate the act, difficulty in initiation the act of micturition.
Right. Hesitancy. Any other?
Difficulty in micturition. So then
Difficulty is poor stream.
post
Stream will be poor. The force will be less. So many things are. If you ask specifically, they will tell all these things. Your patient is 65.
Yes.
You said no urinary complaints. Eh?
Yes, sir.
No. It may be there.
You have asked if there's somebody with the olden age, I mean 70 comes, if there is no problem in passing urine, he must be a diabetic or he must have some other problem. Okay. So among all these things, which is important for you? You are thinking of a hernia.
Yes. Hesitancy.
Hesitancy. See, what are the causes for hesitancy?
In a benign prostatic hyperplasia, the patient can develop hesitancy, sir. Then prostatic malignancies and also
One is not with due to the prostate. Nothing else.
in a detrus or instability, the patient can get hesitancy. Then
Suppose somebody has stricture urethra, what will they have?
there will be alteration in the stream of urine. There will be poor stream of urine.
They will not have a hesitancy? They will. So they will have hesitancy. How will you differentiate the hesitancy due to stricture and prostate?
In stricture, there will be stream of urine will be very poor, sir. He cannot completely evacuate.
Both will have even in the late stage of the prostate also, the stream will be very poor.
Then there will be intermittent stream of urine in a benign prostatic hyperplasia.
In the prostate, what the patient will do? How he pass urine? He makes strain to pass urine. In the stricture, if he strains, urine will not come. He will go stand there still. There will be a drops of urine will be start coming for that.
What is the cause for stricture? Stricture urethra.
Iatrogenic causes
Iatrogenic means what?
secondary to urinary catheterization.
Catheter. You are not supposed to induce catheter.
Then secondary to gonococcal urethritis, the
Yeah,
patient
that is very rare with the introduction of antibiotics. Nowadays, nobody will get the GC urethritis.
then
The commonest is?
Linitis sclerotica also.
No, the trauma. Which trauma? The falling astride. Have you heard of falling astride? The Bailey shows a picture where the person is pushing on one side of the manhole and then he is hitting against that dream is hitting against the perineum. And so also the country boat. The country boat, if somebody is entering and it will slip and he will hit against the perineum. That is the commonest cause for stricture urethra. Rupture urethra is invariably followed by stricture urethra. So that is the cause. GC nowadays we don't see.
So why do you interested in hesitancy? For hernia, what is the reason with the hesitancy and hernia?
Sir, usually they act as a precipitating factor for
How?
development of due to hesitancy, the patient will strain a lot. So there will be increase in the intra-abdominal pressure.
So what will be the normal intra-abdominal pressure?
It will be less than 5 mm Hg, sir.
So straining, how it pressure is increased?
So when he strains,
Sir, it's not 5, I think. Cut off is 10.
The normal is
Normal.
less than. When normally up to 10 will be considered as.
so due to raised intra-abdominal tension,
No, how the pressure increases?
so diaphragm will pushes down, sir. The muscles.
So what?
So pressure is inversely proportional to volume, sir.
Mic is not. Or you are not keeping it close to the mouth.
The pressure is inversely proportional to volume, sir. So when the volume cavity decrease, the volume of the abdominal cavity decreases, so the pressure increases.
But my question is, why there is hernia?
It will push the bowel contents it will push the contents out of the defect, sir.
So have you ever coughed? Have you ever strained? Have you developed hernia? How it is?
So they just act as precipitated as risk factors. So they may not be the cause of hernia, but there may be.
No, how you are protected from hernia?
There are protective mechanisms like obliquity of the inguinal canal is oblique, sir. It is itself a protective factor. Then shutter mechanism where the internal oblique muscle will close the defect, archery fibers will close the defect. Then ball valve mechanism, due to contraction the cremaster muscle will pull the testis and plug the superficial inguinal ring. And slit valve mechanism, while contraction the two cruras of superficial inguinal ring will oppose with each other and close the defect, sir. Then already predisposed individuals, when these when these conditions correlate, they act as precipitating factors and they predispose to hernia, sir.
So why is, even after all these protective mechanisms, still we are getting hernia?
There may be other cause of hernia, sir.
What are the causes?
Even the inguinal canal is already a natural anatomical weakness, sir. Then any collagen disorders acquired or a congenital collagen deficiency.
What collagen disorder?
Like
What is collagen?
Collagen is it is a protein that forms the
Very good.
structural
It is a protein.
that forms the structural framework, sir. Then like Marfan's syndrome and Ehlers-Danlos syndrome, he can
What is the commonest cause for collagen deficiency in the population?
smoking.
So what changes taking place in the collagen?
Due to smoking, there will be alteration in the maturation of collagen, sir. There will be reversed.
What is the normal combination?
Type 1, type 3 ratio will be reversed in these.
What is the normal ratio?
3:1 ratios.
So which one will be increased in smoking?
Due to smoking, the type 3 collagen will be increased, sir.
So any other cause for collagen abnormality?
Alpha 1 antitrypsin deficiency can also.
Is it alpha 1 antitrypsin deficiency alone?
Alpha 1
There is a mismatch between the
alpha 1
alpha 1 antitrypsin and the elastase. So that will produce
collagen
deficiency. What is the common example of that?
emphysema.
Emphysema. What is metastatic emphysema of the reed?
Acquired herniation secondary to acquired collagen deficiency is referred to as metastatic emphysema of ribs.
Whose abdomen is weak? Male or female? Male.
Females, there will be hormones. Males are more predisposed to develop hernias.
So direct hernia is never occur enough because of the collagen changes. So one of the most important cause now we say is only the collagen deficiency or collagen mismatch, collagen problem. More than the cough. Even the cough, when you have all these protective mechanisms are going to help you. But when you are all these ligaments are weak, external aponeurosis is weak, then you are going to get the hernia formation. So that is a significant of asking only the important that. Don't just say there is no difficulty of maturation. You must know what kind of difficulty which is going to be important for a hernia.
So no history of chronic constipation, no history of any abdominal pain, distension, vomiting and obstipation. Past history, no history of similar complaints in the past. He is a known case of hypertension for past 7 years on medications. He takes amlodipine. Not a known case of diabetes mellitus, asthma, tuberculosis, epilepsy and thyroid dysfunction. No history of any previous abdominal surgeries. Family history, he lives along with his family. There are 4 family members. He got married at the age of 25 and have 2 daughters. The elder one is 30 years old and she got married and have 2 children. The younger one is 25 years old and she was diagnosed with Down syndrome, and no history of any connective tissue disorders in the family members.
Down syndrome?
The younger child is affected with the Down syndrome.
So what is it?
It's a trisomy.
What do you mean?
Trisomy of 21st chromosome.
Is there any collagen deficiency there?
No, sir. No collagen deficiency.
Some congenital anomaly is there. So now we know that. So don't categorically say there is no congenital anomaly in the family. Even a Down syndrome is one of the predictors saying that there is some abnormality in the congenital anomaly. So good you have brought out the Down syndrome.
Personal history, he consumes a non-vegetarian diet, he is not an alcoholic or a smoker, normal bowel and bladder movements, normal sleep pattern. Summary, a 64-year-old male who is a known case of hypertension, a petrol pump attendant by occupation, came to OPD with chief complaints of swelling in the left inguinal region for past 2 years. The swelling increases in size on cuffing and can be reduced manually without any risk factors, and no history suggests of any complication. And the most probably...
That means you are reducing manually. How he is reducing?
The patient himself reduces manually, sir.
What do you mean by that?
The patient pushes the contents into the abdominal cavity by himself, sir.
Now, what are the steps you will do when you are doing it, reduce it?
I'll first ask the patient to lie down in supine position, then I'll perform taxis method, sir. First I'll ask the patient to flex the thigh hip and adduct and internal rotate the hip.
Why all this?
By adducting and internal rotation, the superficial inguinal ring gets widened and the oblique muscles of abdomen also gets relaxed.
How the adduction produces the superficial ring get widened?
So the adductor longus tendon is attached to the pubic tubercle, sir, and the superficial inguinal ring is also present at the pubic tubercle, sir.
So internal rotation?
Same movement, it relaxes the widen the superficial.
It brings the internal oblique and external oblique almost in the parallel line.
Taxis is not recommended. What is the problem if you do taxis?
It will be painful for the patient.
Not
sir.
only painful.
And reduction in mass can occur in case of
Reduction. What is a reduction in mass?
So in case of an obstructed hernia, if we push the contents, the obstructed contents can also enter into the abdominal cavity.
And what is the problem then?
So again we have to open the abdomen and look for.
No, the gangrenous loop will go inside if you push it. So you don't identify the gangrenous loop without pulling it out or making a laparotomy. So that is the reason why they don't recommend that. Right.
Most probably a case of uncomplicated inguinal hernia. General physical examination, the patient is comfortable, cooperative, oriented with time, place and person, is well built and nourished, no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no...
Predisposing factors in the general examination for hernia form.
Built and nourishment can influence at times.
Built and nourishment will cause hernia.
Nourishment, if he is a malnourished person or the abdominal muscles may be weak and he can develop hernia.
So obese person is more prone or less obese individual is more prone?
There are some studies that obese person have some protective factors. As an obese person, it's difficult to identify the hernial sac in individuals, so there will be a late presentation in some individuals.
But it will not prevent the formation of the hernia. Somebody going to the exercise, doing regular exercise, what will happen to them? A sportsman are going to gym and doing exercise.
Gilmore's groin, sportsman's groin.
Sportsman's groin. What is it?
It's a tear in the abdomen.
Close, Mike.
Yeah.
It is and the patient will present with the chronic pain.
Inguinal region.
Yes. And radiating to thigh and the scrotum will present with pain due to tear of the oblique muscles or the stretch in the facial defect. The patient.
There is no obvious hernia.
Yes.
So what do you do for the?
Can proceed with the MRIs.
For identifying.
Yes.
Otherwise, if the patient is symptomatic,
should manage him conservatively.
Conservative. Usually you manage conservatively because there is no palpable or visible hernia there. Right. So you should know that sportsman's hernia is there. Groin. It is called sportsman's groin. What is groin?
It is an area that comes into contact when we flex the thigh and the abdomen.
The area above and below the inguinal ligament. The area above and below the inguinal ligament together form the groin.
So exercise is not a cause for systematic regular exercise. Unaccustomed work is maybe a cause because of the muscle tear can happen place. Like somebody who is regularly playing, no problem. Suddenly they will go to the football ground and start playing extensively. They may have the problems with that. Oh.
Vital signs, pulse rate is 80.
Examination.
Local examination. After getting consent from the patient, he is asked to undress himself from umbilicus to mid-thigh. Inspection, a single well-defined pyriform shaped swelling of size 6 × 3 cm is seen in the left inguinoscrotal region extending up to the root of scrotum.
What is pyriform shape?
Form of pyramid-like shape, three dimensions.
Pyramidal. It's not pyriform.
It's like a triangular shape, pear shapes.
What is that pear shape?
It's like a triangular shape. The apex base will be wider and the apex will be narrower.
So that is pyramidal. Base will be wider, apex will be narrow.
three-dimensional form of sun.
Pear shape or pericoid. There will be two bulbs.
Yes.
Above there is a bulge, then you have bulge. That is a typical pear shape.
Cough impulse is present. Skin over the swelling appears to be smooth with no scar sinuses or dilated veins, no visible peristalsis, and the penis is in midline.
You said it's a inguinal swelling or inguinal swelling?
Inguinoscrotals.
So the scrotal skin is also smooth.
So scrotal skin has some rugosities. Rugosities is present in the scrotal.
You said the skin is smooth. What is rugosity?
Due to the dartus muscles,
What is dartus muscle?
it is a derivative of a superficial. The superficial fascia continues as dartus muscle in the scrotums.
So what is the other connection of that?
It's sort of some protective mechanism. So when the temperature is less, the muscles contract and push the testis upwards into the abdominal cavity.
So what?
So that the spermatogenesis will not be affected. The adequate temperature for spermatogenesis.
How the temperature is maintained?
By pushing it near the abdominal cavity.
So what is that mechanism? What is the physics?
The dartus muscle will
Contracts. So what?
in response to cold temperature or some.
Cold it relax. So that's more surface area it creates for the heat to evaporate. When there is like when you have a coffee, hot coffee, we put on a plate to reduce that heat. So when the large surface area, the more heat will be evaporated outside, less heat will be conserved. So the Maharaja testis will always live in the AC room. So always you maintain an AC. By maintaining this, that is why it is very important. Okay. So dartus fascia connect with the superficial fascia, Colles fascia.
On palpation, there was no local rise in temperature, and there was no.
How did you palpate?
So with the undersurface of the hand, I first palpated over the normal region, and then I palpated over the swelling to look for the rise in temperature.
Why do you palpate at the base of the? Why not palm?
So it has more sensory receptors than when compared to the palm. So palm has relatively thick skin, whereas it has a relatively thin skin in the palms.
Okay.
So all inspective findings are confirmed. A single well-defined.
I'm sorry. Inspectory, that word is not there.
Not ideal.
In the dictionary. Inspection finding is enough. Or you want another ROI. All inspection findings are confirmed. Enough.
A single well-defined pyriform shaped swelling of size 6 × 4 cm situated in the left inguinoscrotal region, extending up to the root of scrotum. The skin of the swelling is normal with smooth surface. The swelling is soft in consistency.
You
And
can say normal. There is nothing wrong in saying normal. But only when you say smooth, it is a problem.
Again, the location. Any swelling location is the most important thing. So what you should say is whether your swelling is above and medial to the pubic tubercle or below and lateral to the pubic tubercle. The swelling is above and medial. That is the location. That is inguinal. If it is below and lateral, it is femoral. So from the very beginning, palpation after your temperature, tenderness, your inspection finding, you feel the pubic tubercle and then decide whether the swelling is above and medial or below and lateral. If it is below and lateral, your total focus will be on femoral hand. Right.
the swelling is soft in consistency and expansile cough impulse is present.
What do you say it's expansile cough impulse?
Usually the swelling is in contact with the abdominal cavity. When the patient coughs, the more the bowel, more the content will enter into the swelling. So palpating the fingers will move apart. There will apparent increase in the size of swellings.
What are the other causes for cough impulse in that case?
In the scrotal
scrotal swelling.
Yes.
What are the other causes for cough impulse?
So varicocele can also the cough impulse. Then lymph.
So how will you differentiate these?
Actually, in a varicocele, it will be a form of a thrill-like impulse, and the varicocele does not reduces immediately like a hernia, sir. It takes some time.
We are talking only about the cough impulse.
We can, it will be thrill-like impulse in varicocele, and even Safina
What
varix.
is that thrill like? What is that expansive? You said moving apart. Is that only thing?
Sir,
Moving apart is expansive.
so there will be a momentary increase in all the three-dimensional.
Three-dimensional.
It will be increased.
Lift and apart. Both will happen. So how do you check for that?
So I'll, with the thumb front and the other fingers behind, I'll hold the root of the scrotum and ask the patient to cough while coughing.
So after reducing or not reducing?
So without reducing.
Without reducing. So non-reducible swelling also you can do a cough impulse.
So no, sir. Non-reducible swelling will not show cough impulse.
So always after reducing, not without reducing.
What are the two cardinal features of hernia?
So the two cardinal features are reducibility and cough impulse.
When you won't get these two,
In an irreducible hernia or an obstructed hernia or a strangulated hernia, we will not get these.
so then how will you say it is a hernia?
So based on the location, hernia will be often above and medial to the pubic tubercle in the inguinal region. We can.
Not reducible, there is no cough impulse. Then how will you say it is a hernia?
So location, sir.
Then what is the differential diagnosis?
No, it is a obstructed hernia. How will you say it is a obstructed hernia?
There will be features of obstruction in the patient.
Which is obstruction.
Okay, irreducible. If it is a irreducible hernia, without obstruction.
I am saying it is hydrocele.
So get above the swelling will be present only in a hernia. Get above swelling will not be present in a hernia. It will be
What do you
present
mean
in.
by get above the swelling?
You can palpate for the contents of spermatic cord in the top of the swellings.
Only the contents of the cord can be palpated, no other structure.
So all the hydroceles are get above the pelvic positive.
No, sir. In some encysted hydrocele of cord, we cannot get.
Encysted you can get.
Sorry.
You can get above or
Above.
below.
It is not a big thing.
Congenital hydrocele we cannot.
Lot of congenital hydroceles.
Infantile hydrocele.
Infantile. So why it is not there?
Because the hydrocele occurs due to the patent processes vaginalis, so we can't get above the swelling.
What is hydrocele and Bisac?
Hydrocele and Bisac, it is hydrocele in a patient with long-standing hernia. It's known as hydrocele and Bisac.
No. That is
Hydrocele,
hydrocele of hernia.
that is hydrocele. This is hydrocele and Bisac.
In long-standing hernia patient,
No,
long-standing
no,
hydrocele.
Nothing to do that.
nothing to do with hernia. The sac, the hydrocele sac, that is the with fluid. It has got two portions. One in the inguinal, it will go up in the inguinal canal, maybe up to the deep ring, and the part below. So,
Encysted
Like what is the pyriform shape? You get one something goes up.
encysted hydrocele.
Can you
it
tell
is
the
not
layers?
encysted.
It's not encysted. Can you tell the layers of scrotum?
The layers of scrotum or skin, dartus muscle, then the external spermatic fascia, cremastic muscle and fascia, internal spermatic fascia, and the tunica vaginalis.
How many layers?
Two layers, visceral layer and the parietal layer, tunica albuginea and the tunica vasculosa.
Go ahead.
So anybody from the audience, how will you say there is a irreducible hernia without cough impulse and the irreducibility? How will you say it is a hernia? So here history taking is very important. Previous history of a reducible swelling, now it is not reducible.
Okay, go ahead.
The swelling is manually reducible and it reduces with a gurgling sound. On deep ring occlusion test, the swelling does not appear medial to the occluding finger. On Zeeman 3-finger test, the impulse is felt on the index finger and the ring invagination.
Why do you want to do Siemens test?
So if we suspect femoral hernia, we
So you are suspecting femoral hernia here. In the deep hernia examination, we want only you to do a deep ring occlusion test. Only when you have a doubt whether it could be a femoral hernia, then you want to do the Siemens test. Siemens test is not you are going to differentiate direct and indirect. So deep ring occlusion test is the only test which we insisted you on to do it appropriately. All others are only for a theoretical sake. And that is only for when you have a obvious inguinal scrotal hernia. We will not never do the finger test, and even if the ring invasion test is also because of the pain for the patient, we are not going to do that.
So the problem with semen is your DAS. DAS is describing that the middle finger should be on the superficial inguinal ring. The direct also is coming out through the superficial ring. So what originally Seaman described was the middle finger should be over the direct hernial site. What is the direct hernial site?
The hernial sac that comes out.
What is the direct hernial site?
That comes out through the Hasselbeck's triangle.
Hasselbeck's triangle. So he described that the middle finger should be on the direct hernial side, the index finger over the deep ring, and the ring finger femoral. So misinterpretation, and finally it has come out in DAS as over the superficial inguinal ring. The indirect also is coming out through the superficial inguinal. You know that. So that is a problem. Better if you don't know well, and if it is not essential, why you should mention Zeeman? You find out whether it is direct or indirect by the ring occlusion test. Then you make your own findings to fit into the Seaman's type. So better if you don't know how to do, and this whole spirit of the three finger is finished once you say that the middle finger is over the superficial inguinal. So better not to tell. As long as your examiners are not insisting for it, don't mention. I don't insist my students. Sir also is not interested. So that's a problem also, the description problem by DAS, right?
Percussion, a resonant note is heard on percussion, auscultation, bowel sounds heard on auscultation.
Position you percuss?
Patient in supine position.
No.
Standing position I percuss.
Because in standing position only the intestines will come down. Otherwise there is no meaning in percussing. You want to know whether the intestine is there or not. That will come down only in standing position. So percussion, if at all you are doing, it should be in standing position. In which position you did the ring occlusion test? In which position you did?
First I made the patient to lie in supine position and I reduced the swelling.
Yes.
Then I palpated for the deep ring and occluded the deep ring and I asked him to stand and
stand up. And then?
Cuff.
Yeah.
And I asked him to stand and cuff.
And then you check. Yes. So that is the correct way. Similarly, for auscultation also, make the patient stand. So the position for hernia examination is basically supine or standing?
Standing.
Standing. So that you should know. Any hernia patient, the basic position is in standing position. Then for reducibility, you keep the patient supine. For ring occlusion test, again, he should be in standing position. For percussion also, he should be in standing. These are all basic dictums, right?
Other common mistakes you do, a small hernia will be there. As soon as patient lies down, it will get reduced. For those cases, please don't come and say, I have done a percussion, I have done an auscultation. The swelling, as soon as he lies down, it is going up. And even if it is standing, a small swelling come, it is very difficult, you go do a percussion, it is not going to give a much value for that. So, swelling like this, large swelling, okay, yes, you are justified in saying that you have done a percussion test.
Examination of right inguinoscrotal region, no visible coughing.
Vowel sounds can be heard on auscultation. Where you auscultate?
Over the swelling.
What is swelling? Swelling you are able to get the vowel sound.
For
What's normal vowel sound? Rate of vowel sound?
So around
Usually where you will auscultate for
in the left iliac fossa, the sigmoid colon around the left iliac fossa I'll auscultate.
No, it is not left iliac fossa.
Sigmoid colon I'll auscultate.
No, it is always, where do you get small intestine? It will come finally to the right iliac fossa, right side only. So never on the left iliac fossa. It is on the right iliac fossa. Right. So sir is asking why you have, or where do you place the stethoscope for the bowel sounds over the hernia. That is what sir is asking.
So over the swelling he waited, then I heard for some gurgling like sound, heard auscultations.
Why you have to auscultate the abdomen for bowel sound in a hernia?
So an abdomen to look for the bowel sounds out.
So what's the normal rate of bowel sound?
So around 3 minutes.
You are saying 72 per minute, no? Similarly, bowel.
So around 3 minutes once I can hear a bowel sound.
3 to 5, 3 to 5 per minute. So what is barbaric?
Exaggerated bowel sounds is known as
So when
barbaric.
there is upset hernia, you will hear barbaric.
What's the diagnosis?
Diagnosis: a case of left-sided, uncomplicated, incomplete indirect inguinal hernia, probably enterocele, PL2 according to European Hernia Society classification and type 2 according to NIAS classification.
So how you are going to proceed?
So first though hernias are
At least one of the gradings, if you are saying it is good, but what if you say this must be correctly, must say either European classifications or NIGAS or Gilbert, any one of these.
Hernia is usually a clinical diagnosis, but to confirm the contents of the sac and to assess the size of the defect, I will perform USG.
Which defect?
Deep inguinal ring defect. I will perform ultrasound abdomen and pelvis. Then I will also look for post.
Taking anticipatory bail hernia is a clinical diagnosis. Why? Because nowadays, I don't know about Tamil Nadu, they don't pay money if you don't do an ultrasound. The insurance companies, especially the scheme, the card scheme, they don't pay if you don't do an ultrasound. So we want to know, maybe the only advantage is, the ring size. Any other finding is there? Those things, any abdominal associated problems, what is the cause for acute hernia? Mention on cause for acute hernia. Yes, correct only. Yes. Anybody? Yes? Ascites. If patient is developing ascites, the patient will not only inguinal, sometimes even umbilical hernia will occur with acute malignant ascites and portal hypertension, cirrhosis. All those conditions will develop. Along with that, a hernia also.
What's the other indication for ultrasound in old age with hernia?
So we can look for post-voidal urine. To rule out BPH, I can look.
What is the normal residual volume?
So 30 to 50 ml is the normal residual.
No, normally there is no residual.
No residual. You should pass urine completely.
Normal adult, healthy adult. For old patient maybe, but normal healthy adult, if you go and pass urine, no residual. That is there. 30 ml may be there for this patient. And also the prostatic volume can be ascertained by ultrasound.
The ultrasound of examination is mandatory for the documentation. Now all the cases you need to do what grading you have to write, so that you need to do associated features to any other mass, prostate, urine, all that has to do it mandatory. And you can sometimes diagnose the symptomatic maybe in the one side, and other side also we will be able to see in the preoperatively also.
Then chest X-ray.
All investigation confirmed, because we have only 5 more minutes for you.
Then I'll proceed with the management, sir. I'll do.
Louder.
I'll proceed with surgery, sir. First I'll discuss with the patient.
At your whims and fancy.
So I'll discuss with the patient. There are two procedures: open procedure and laparoscopic procedure. Then with the patient, what the patient is willing, I'll proceed with that surgery, sir.
So if you have no laparoscopy facility, but the patient wants laparoscopy facility.
Sir, I'll perform. I'll convince him for open.
One question. What is the
Confused and convinced.
anesthesia of choice for an open hernia repair? I'm not asking whatever you are seeing. what is the ideal anesthesia for an open hernia repair?
So regional anesthesia.
Regional means
Spinal anesthesia.
spinal. Actually, there are centers world over, like the Shoulders Hospital in Toronto, in Florida, the Gilbert's Hospital was there. They do all hernias under local anesthesia. So you save the anesthetist time, you save the anesthesia materials, you will do always under local anesthesia, which is not possible for a keyhole surgery. That is the first thing to remember. So you decide open or keyhole or laparoscopy, you know various factors including the finites. But the basic thing is that you cannot do a laparoscopic hernia surgery under local anesthesia. That also is there. Because they have shown results anesthesia. Florida have gone and seen. They do hernia under local anesthesia, then immediately after the surgery they give some flexion, the knee, thigh flexion exercise, and then the patient will come out after 3-4 hours. The patient will drive home. That advantage is there.
Okay. So what is final? What is the indication for doing it up?
So bilateral and recurrent hernias.
Okay.
What are the types of laparoscopic hernia repair?
So totally extraperitoneal repair.
TAP, it is TAP. And
TAP. Sir.
TAP is
Transabdominal preperitoneal.
preperitoneal repair. So what keyhole is being done in your hospital?
Tap.
TAP or TAP.
Taps.
Open, have you seen? What is the incision for open hernia repair?
So we'll make a longitudinal incision above.
Longitudinal.
Transverse incision along the medial.
Oblique or transverse?
Oblique along the medial half of inguinal ligament.
Medial 2/3 of the inguinal ligament. Then
I'll insert skin, subcutaneous, campus.
what are the layers of the superficial fascia?
There are 2 layers, sir.
What are they?
Louder, ba? Kya matanga?
There are campus fascia, superficial fascia of camper and scarpus fascias.
Yes. And then what are the vessels there?
So there are superficial vessels, superficial epigastric, superficial circumflex iliac and superficial external pudendal.
So you may have to divide those. And then?
Then external oblique aponeurosis.
So you open that?
External oblique aponeurosis, and I opened the inguinal canal.
That you are inside the
inguinal canal.
What is the open repair you are doing here?
Lichtenstein tension free.
Tension free repair, right? Right.
Thank you. Well done, Sokalingam. I'm going to keep it up.